Well, what I'm going to talk about tonight is something that no one's ever heard of, and there's several aspects that no one's ever heard of. That's my specialty, right, Cynthia? I talk about these sort of crazy new things that I think are really explain a lot about dry eye that we haven't realized in the past, and which makes it a really fun subject. I mean, I'm crazy about this subject, dry eye, and crazy, Cynthia, as you know, about biofilm. So what this is about tonight is ending dry eye as we know it. And I think we can do it now, and it all comes with knowledge. Biofilm, right? Biofilm's had its way with us for the last million years. Well, guess what, folks? Now it's our turn. We're going to have our way with biofilm. Now, in 2013, no one had ever heard of biofilm in terms of, of any eye disease. Dr. Perry, along with myself, presented the unification theory back in 2015. And I think since then, it's pretty much gotten around. I think everyone's heard of biofilm these days. I used to get blank stares at meetings, and now everyone pretty much accepts that biofilm right here, peeling up off this eyelid, is really a major source of this inflammatory disease we call MGD or dry eye disease. So I'm not going to go through what I used to have in my original slide there talking about biofilm. I mean, we went into a lot of detail, a lot of explanation as to the whys and hows of biofilm. Most people have heard of that by now. But just to give a real brief thumbnail, biofilm is a sticky polysaccharide film. It's produced by virtually all bacteria in nature if they have moisture. And inflammatory valence factors are produced when bacteria get to live in that biofilm, once that biofilm gets mature. And this biofilm on the lid margin you see here, it resists all methods of removal except really one thing, BlephEx, used on the surface of the eyelid. But this discussion tonight is not just about BlephEx. BlephEx has been out for a while. We're reintroducing not just BlephEx, but a brand new protocol in treating dry eye disease that uses BlephEx along with a brand new device we're just now introducing, Cynthia, just now launching into the marketplace. Brand new. You're one of the first groups to hear about this. But just real briefly, how does this theory go with biofilm? Well, bacteria want to survive. They build biofilms to live in. That lets them increase their numbers. That turns on quorum sensing gene activation, which then begins producing these bacterial toxins. Those toxins cause inflammation. Long term, that inflammation causes the damage, starting in follicles, then meibomian glands, and much later on in life, we end up with the lacrimals being involved as well. So staph produce biofilm on any surface as long as there's moisture. Then they start producing toxins. So the bacteria live there quietly, don't bother us until they're in a biofilm. Then they don't worry about the host inflammatory response. They don't worry about making toxins and the host attacking them. They're safe. The host can't get to them inside of a biofilm. Biofilms are impenetrable. So then they produce toxins, triggers the immune system, and that's what produces inflammation. The inflammation slowly and painlessly destroys the meibomian glands that we know as MGD, dryness and redness of the result. Well, the new protocol that we've discovered that actually can put dry eye essentially in remission is called the REVVE protocol, REVVE. And that stands for Recognize, Exfoliate, Vaporize, Vibrate, and Express. Now, this recognition part, boy, we've been struggling with that for a long time, haven't we? How to recognize when a patient actually has MGD or when it's allergy or when it's whatever it is. Uh, we've had an industry pouring millions of dollars into diagnostic devices, trying to recognize when it's this inflammatory MGD and or dry eye disease. There's some indicators out there that people mostly know about here, but we've come up with something that we think that's a little bit simpler and easier for most practices to implement in their waiting room even before the patient gets back into the lane. It's called the DSB line. DSB stands for deep subdermal blepharitis, which is what this disease actually is. So when was the last time you had a conversation with someone, you're talking about dry eye disease, and they use the word blepharitis, and you say dry eye, and they say blepharitis, and someone says, well, how about red eye? You have a lot of confusion when talking about this disease. Is it dryness or is it meibomian gland disease? Well, we should call this disease what it is. It's blepharitis, it's lid inflammation, but it's below the skin. It's deep subdermal blepharitis because that's what's destroying the meibomian glands. And there's a sign now that we've discovered that really makes it easy to diagnose this disease. It's this DSB line that you'll see right above the upper lashes and right below the lower lashes. Now, this sign is on every single one of your MGD patients, but it hides from us in plain sight. And I'm going to show you how to find that sign here in just the next couple of slides here. But first of all, let's talk real quick about meibomian glands, and then we'll get back to the DSB line. So here's what you would consider a fairly normal set of meibomian glands on meibography. And I do meibography on all my patients. That's one of the first things we do, even on their initial examination before we can start treating. And this patient, I would say, look, your glands look good. They're full length. We're not having any big dropout. I love the fact that these glands have a lot of cobblestoning, these little white dots. Those are the individual oil acini within each gland. If I see a lot of those, I can tell the patient, you're going to be a fairly easy fix to get your dry eye under control because we've got lots of oil-making little sacs here. But what I don't like about these glands is the early base splitting. So this is how meibomian glands die. They split off. The base is split off. Here's a split. There's a split. Those pieces will die off. There's another split over here. A little bit piece is going to die off there. Here's the big split right here. The entire base of this gland, remember we're upside down, the entire base split off from the rest of the gland. This part shifted over, shifted down, and that will die off. And this goes on over the years, and we gradually lose our glands. They get disorganized. You get patches of glands where you can't even tell what piece went with what gland originally. They just get sort of blown to pieces by slow chronic inflammation. Here's what the end result, well, not the end result, here's what a later result ends up being. But even this patient has cobblestoning. This patient's capable of making oil, probably to the point where they'll be asymptomatic, but you see all the loss and the disruption of the glands. And here's an even more severe case, but even this patient has cobblestones. And believe it or not, even this patient can get good oil production back if the clinician is diligent in saving what the patient has here, not allowing any more damage and getting these guys working again. But let's get back to that DSB sign again because it correlates beautifully with meibography we've discovered. You see the red line here and the red line here? Which one's the worst? Well, this one, right? Which eye has the worst meibomian gland damage? The same eye. Because it's worse inflammation. This inflammation, this line is directly on top of the meibomian glands. That's why it's red. The glands are on fire. And directly under that, it's these glands. Well, these are the lower lid, but it's the analogous glands in the upper lid, and they're being slowly destroyed. It's right there in front of us. Here's another red line here. There's one here. Which one's the worst? Well, this one again has the worst damage here. Another red line there and a red line there. Look at the breakup of the glands that occurs over the years. So this sign's never been recognized before. I mentioned this and talked to Hank Perry about it. I said, Hank, has this ever been discussed in the literature? So we did literature searches and all that. It's never been talked about, never been described. And the reason is we don't examine patients with their eyes closed, right? You put your chin on the slit lamp, you look at my ear, open your eyes, and we don't even do a closed eye examination. Now we're beginning to do a little bit more with XDEMVY promoting the evaluation of the upper lids for the collarettes. But it used to be we didn't do it at all. And this thing would hide right in front of us. In fact, it still hides. The patient can even close their eye and you won't see this unless you implement this little trick that we've discovered. It's also not recognized because we don't interact with each other with our eyes closed. Obviously, we open our eyes, we look at each other. We don't see each other's red lines. But this right here is the fastest and easiest way to diagnose inflamed glands. It's right there looking at us. The front desk could diagnose this. A tech can diagnose this before the patient even sees the doctor in the exam lane. The diagnosis is right there in a picture on the counter in the lane. Friends and family can have fun diagnosing each other. You don't need any expensive equipment. You don't need any testing. All you have to do is pull up on this excess skin and give it a little stretch, which is an important part. Now, the only exception is if the patient's had IPL, that can hide a lot of this. So I never recommend IPL as an initial treatment, but it certainly is a good add-on once you've had several treatments under your belt to get rid of the biofilm. This is a good way to follow patients' progress because these red lines fade away. And I'm going to show you pictures of that here in just a little bit. So you have to have one instrument. I didn't mention this instrument you need. You need this right here. We got one of these on the end of each hand. It's called a thumb. You lift up the skin, but you don't just lift. You have to stretch it. If you just lift the excess skin, you're going to be left with little fine wrinkles here. And it's unbelievable how these little fine horizontal wrinkles will mask this redness. You won't see it because they suddenly get enveloped in little shadows caused by little wrinkles. So you got to lift it and stretch it. If you start checking your patients in your offices, you're going to be blown away by how many patients have this disease we're talking about. And the value of this sign, therefore, is in diagnosing patients earlier before they become symptomatic. Isn't that really the holy grail? To catch this disease early, we'll have a more successful treatment, and we preserve a lot of meibomian gland tissue the earlier we treat. So we don't want to wait till the patients have dry eye before we start treating. That'd be like the dentist saying, well, we'll wait till you lose a few more teeth before we do a dental cleaning or recommend a good hygiene program. You want to prevent this disease. So this is how you diagnose your patients. As soon as they have any inflammation of the meibomian, you're going to pick it up. Every patient walking in your door that's past age 50 needs to have their upper lids looked at and a picture taken of it. I absolutely agree with Dr. White that pictures are absolutely worth a million words in taking care of dry eye because you can show the patients and you can follow progress. We set up this DSB grading line scale that shows normal through stage 4. It just shows how that line can get worse and worse and worse as the disease, you see, gets worse and worse and worse. They just go absolutely hand in glove. Who knew it was so easy to diagnose inflamed meibomian glands? But there it is. And once they're inflamed, it's going to cause damage and it won't stop until we end the inflammation. So we developed a little brochure based on this. You put this in your waiting room and ask the patients, do you have DSB? Now you see all those commercials on TV, right? Do you have PMF? Ask your doctor if this treatment's right for you. They always use letters for their disease. So we did the same thing. Do you have DSB? Which means this line. It's the silent killer of your tear glands, this deep subdermal blepharitis. Ask our front desk or ask your technician to check you and see if you have this. So we want the conversation to get started because what this is going to do is pick up your asymptomatic patients. Asymptomatic patients, again, that's the key. Get the conversation going. And then the back page talks about the treatment protocol that we're going to delve into a little bit further now. So that was the recognition. That's the R of REVVE. The E is exfoliation. Now, BlephEx has been out for a while. Everyone knows about using a BlephEx to do a microblephexfoliation. This removes the saran wrap, that biofilm layer, from the lid margin. That layer seals off the gland. So even if they're producing oil, it can't come out. You got to get rid of that first. And here is a bunch of collarettes that Dr. White alluded to, collarettes on the base of the lashes. You know this patient's got Demodex follicularis anyway. And that's another good reason to use BlephEx. You remove this stuff here, and afterwards, guess what you might see on high mag? A little Demodex there, there's one here, there's one here. So they show up. Now it's going to be a lot easier for XDEMVY to do its job in killing these guys. So you've got to get that stuff off the lids if you're going to do anything dry eye or MGD related. Here's a really interesting value of doing doing a BlephEx exfoliation prior to an expression. And I was pointed this out by Dr. Jeff Cincino here in Nashville. It compares a traumatic expression versus non-traumatic expression. And what that means is this is a paddle that's going to express this eyelid without a BlephEx done first. So what he's doing here, he has to squeeze so hard that you're popping that sludge, that solidified oil down on the gland, you're popping and rupturing it through a biofilm layer. So it comes out like silly string. Takes a lot of force to do that, not very comfortable. You run the risk of causing a chalazion because these glands are inflamed. They have weak walls, these meibomian glands. So this is a traumatic expression versus once you've done a BlephEx over here, now look with a little bit of expression with an Ilex device, look how it just rolls out. Just wants to run out of there. There's no silly string. So if you ever see silly string on an expression, you're doing a traumatic expression. You got to get rid of that biofilm first. And here's the guy that really pointed that out to me, Dr. Cincino here in Nashville. He did a little video showing how you express here first before a BlephEx procedure. And then the other half of the lid, he's going to show what it looks like after you do a BlephEx exfoliation. Now, there's a silly string. He's squeezing and making it pop out through little bitty breaks in that biofilm layer, squeezing really hard, not comfortable. And then watch what happens when he moves to this part of the eyelid and does an expression after a microblepharoexfoliation procedure. Now look at the difference. It just wants to just blow. Look at that. It just comes out big gobs. Atraumatic. You don't risk the health of the meibomian glands, and it's not nearly as painful because it doesn't take as much force. So if you're expressing out there in ophthalmology land or optometry land, get your patients expressed, but do a BlephEx first. All right, what's the first V? Well, we talked about bacteria colonizing the glands. They produce biofilm, which is their glue to keep their biofilm in position, intact, so they don't get dislodged easily. Well, that's on everything. That's on the walls of the duct. That's in the acini. It's everywhere. And when I invented BlephEx, I thought, well, great, I'm getting rid of biofilm on the surface of the eyelid margin, but what about down where it's really important inside the meibomian gland? I can't scrub that out. Well, now we can. We scrub it out by vaporizing it. So that's the only way to get it off. So we use a triphasic harmonically tuned current, and it literally blows these bonds apart in this biofilm, blows it into a vapor. And that makes all the difference in the world. This is the game changer in dry eye disease because we can now finally get the biofilm out of the glands where it's doing all the damage. Now, where I learned about that was from Montana State University Center for Biofilm Engineering. They grew a biofilm, a Staph aureus biofilm, on a metal plate. They hooked it to these grounding rods and submerged it in a saline bath, and then they ran in a copper wire, and they flipped the switch to a 6-volt battery, 6-volt current. Here's what happens when you run 6 volts of electricity through the wire, through the saline. It's got to go through the biofilm to reach the plate, which is grounded out. Here's what happens to biofilm when you put a 6-volt current through it. This right here, folks, this is our enemy in MGD. This is biofilm being blown in, literally blown into a vapor. And we can now do that in vivo, inside the meibomian glands. You loosen it up, you blow it off the walls, you blow it out of the oil acini, and now you can get it out of the glands. And this is what Optivize does. Optivize has this little specialty contact lens. This is how we deliver the electric current. It's this little scleral shell, essentially. It's got a shelf that sticks out of it. So this goes in the eye, but the shelf sticks out between the lids. So the lids close on this shelf. So the top lid touches this shelf. The bottom lid contacts underneath where there's another metal plate. There's a little hole here and a little hole there. So you can bring an IV line in right here. You drip out saline solution very slowly out these little holes, keep things moist. So we get good current conduction, and you'll get a nice uniform, comfortable vaporization. The current comes in through this right here. Oops. And that's what this side of the Optivize controls, is this little device called a VCL. It stands for a vaporization contact lens. Here's the patient getting it done right here. Here's it in the eye. You put a little 4x4 gauze over that. She holds it in place. And in 2 minutes, that eye is done. And you just take it out, switch it to the other eye. 2 minutes later, that eye is done for the first time without biofilm, or at least without intact biofilm in the glands. Then we got to get it out of there, right? We have to mobilize it, right, Cynthia? We don't want it staying down in that gland. So how do we mobilize it? We've got to do a heat and manual vibratory expression using the other half of the Optivize device. It's a little handheld device similar to an iLux. Slips over the lids, got a little observation lens there. The only difference is not only are we going to heat and express, but this outside paddle that comes in and does the pushing has a little vibrating disc on it. So now we're doing a vibratory expression. Vibration mobilizes things. If any of you old guys out there like me remember way back in the 70s, I guess, we had this little football game as a metal sheet and had little football players that are on some kind of little Velcro. They sat on that metal sheet. You flipped the switch, the metal sheet vibrated, and they moved around. Cynthia, do you remember that? No, you're not old enough, Cynthia, but I had one of those games. It was a lot of fun to see whose football player made it to the end zone because vibration mobilizes things. And it does the same thing here. So we can do the most thorough expression that's ever been performed, especially in light of the fact that now we have the biofilm vaporizing, just sitting there ready to come out. Here's the first ever picture of biofilm that's been removed from glands. I started seeing this in my early patients. I thought, what the heck is this stuff? I'd never seen this sort of particulate debris, this granular, these particles. I'd always seen this sort of a white lipid looking, white fatty looking stuff here, like melted Crisco here. But look at this stuff here staying completely separate, not going into that oil, not going into that melted sludge. Conferred with my most favorite ophthalmologist in the whole world, Dr. Hank Berry, and as Cynthia knows, and we determined it's got to be biofilm. There's nothing else that's going to come out since we're now vaporizing. So right there it is. It's sugar essentially. Sugar is water soluble. It's not fat soluble. So it stays totally distinct and separate. And then once you finish melting, now it all comes rolling out of there. All this sludge here now comes rolling out with an achromatic expression. Have you ever wondered what that stuff is? What do we call it? Disease meibomium? But what is it really? Have we ever had a course on that? Ever had anyone lecture about that? Well, I'm going to explain to you exactly what that stuff is so you'll know you can tell your patients. So remember that once in a biofilm, staph produce toxins. They have to have moisture, of course. That's on the eyelid, margin, and within every structure. And most strains produce one of two enzymes, either a lipase or esterase, but not all, but most, lipase or esterase. And what's interesting about those two enzymes is they esterify oil. So we have this nice little simple oil molecule that's nice and clear. Liquid wants to come out, lubricate our eyes, give us clear vision. Bacteria say, I'm going to hang a bunch of ester chains on that little molecule, and I'm going to make it this great big complex molecule, so now it can't get out of the gland. I'm turning your oil into a solid by this enzymatic transesterification. That's what bacteria do to our oils. Well, that made me start to think, well, why do they do that? Why do they go to all the trouble and exert all the energy needed to convert our oils into a solid? There's got to be a reason, and there is a reason. Millions of years of evolution. And survival over those millions of years was all about one thing, having a stable food supply. So what bacteria are doing is they're taking our oil that could escape the gland, that's their food source they start with, and they're turning it into a solid that stays in the gland. So they're building themselves little pantries full of Crisco. Now you can tell your patients when you squeeze their glands and you get that goop out, you say, well, that's your bacteria's Crisco I'm getting out of your glands there. Does anyone use Crisco anymore? I don't think so. I think we've all gotten away from Crisco because of trans fats and all that stuff. But hey, in my house, Crisco is still a thing. We did a little study that showed an average tear breakup time increase by 7 seconds per eye, 0 complications or adverse effects. These treatments are monthly until you get clear oil, and you take a picture at each visit so the patients watch their sludge slowly turn into beautiful clear oil, and their symptoms go away.
Jim, do you do the vaporization and the expression, meaning the REVVE procedure at one session, or
Yes.
do you do one and then bring the patient back?
One session. And from beginning to end, it's about 20 minutes. Now, my initial exams, they take about an hour because I go through a lot of the science behind it. I take a lot of preliminary photography and talk about the biofilm and the REVVE protocol. But once they're in the system, it takes about 20 minutes to do this whole thing, BlephEx all the way to expression. So what happens after you do a number of treatments on these patients? Here's the red line. There's that DSP red line. After 5 treatments, this patient's red line went away. Here's the left eye, same thing, went away. Now, I'm not saying all patients are going to have success after only 5 treatments. Some might take 15 treatments. Some you'll see this line diminishing in maybe 3 or 4 treatments, but be patient, it will happen. Look at this older gentleman. Really a severe red line here and on the lower lid. His is still there, but not near as bad, right? And look at the lower lid. That red line's completely gone after 7 treatments. That means only one thing. We are decreasing inflammation because we're getting rid of that inflammatory biofilm within the glands, not just on the lid margin, within the glands. Look at the edema of the lid margin here. My gosh, that is severe edema. Look at it after 6 treatments. It's still edematous, but nothing like it was initially. You will make profound changes in your patients. Look at the lash line coming back in there. The red line here going away. Here's a good one for the lashes. See how there's gaps here in the lash line? They start filling back in after 6 treatments. The eyelid is very happy when it's not inflamed and everything works the way it's supposed to work. So they say this red line is so easy you can see with their eyes closed, meaning obviously the patient, right? In as little as 3 months, you go from this to this to this. And there it goes. Inflammation is going bye-bye. And that's the holy grail of treating this disease. Here's my star pupil, and I'm almost done. This lady came in, and she was the worst inflamed patient I'd ever seen. Her sclera were injected, her lids were hot, all the way up into her forehead. This picture doesn't do it justice. She was inflamed all the way up into her forehead here. She was absolutely miserable. Look at the swelling of her lids after 6 treatments. Look at this lady. She says, I got my life back, Dr. Rynerson. This lady was actually contemplating suicide, or at least had thoughts of it, because you don't realize how miserable these patients are. They can't enjoy 1 second of any day without thinking how miserable they are with their eyes. It affects everything they do. She was the second patient I had said that. I had a 77-year-old radiologist that said the same thing. I can't fly my plane anymore. I can't go boating anymore with my sons because of my eyes. So this treatment is a game changer because it finally turns the tide on this disease. And we've never been able to do that before. Before it was always just manage, this drop, that drop. Now we're turning it around. That's what we should be doing as clinicians. So that's what we're doing. We're getting serious about removing biofilm on and within the eyelids. We should all strive to do that. And these are the products we used to do it with. And with that, I'm wrapping up. I hope I got done in time, Cynthia, and I'll turn it back over to you. But thank you very much.
Jim, that was really literally an eye-opening lecture. The DSB, I had never heard of it. This was the first time I heard it. Thank you for enlightening me and our audience too. And thank you for discussing your in-office procedure, including the digital imagery to help our patients understand what's going on, the BlephEx to remove the biofilm, and then the REVVE process, to vaporize and express. So you've really shared so much with us. We really appreciate all that you've taught us. Truly appreciate your time tonight. Thank you very much.
Very, very humbling. Thank you, Cynthia. I appreciate your words. Any questions?
Well, we had the one about doing it sequentially or at the same time. And then you said you keep doing it monthly until you get clear oil. That's
right. And then once you get clear oil, you move your interval out, not to a month anymore. You go to 6 weeks. If that's still clear, you go to 2 months. If that's still clear, you go to 3 months until you have your patients on it every 6 months with clear oil, healthy lids. And then it becomes just like a dental cleaning. And the patients are used to that already. Every 6 months to maintain healthy oral cavity. It's the same thing here. Every 6 months to maintain healthy lid environment, healthy oils.
Right. And patients are used to that. They know they have to do that for their teeth. They know they have to do that for other types of medical problems. So 2 or 3 times a year, I felt my patients at least never minded that.
Yep. Absolutely.
That's great. And I take it that there is no insurance code for this. This is a cash pay procedure. Is that correct?
Yeah, it's advanced technology procedures. Insurance just won't cover advanced technology procedures. So it's going to be a long time before they cover these. Cynthia, it took them 18 years to cover mammograms. So if you think back, that's really a shame it took that long to cover something that could kill you. So yeah, covering something for dry eye, we don't have our hopes up that that's going to be covered anytime soon. So it's cash pay.
Sounds great. Well, thank you again, Dr. Rynerson, for an excellent presentation. We really appreciate it.